Good afternoon and welcome to What's Up Doc, a lecture series brought to you by the Concord Hospital Trust. My name is Tia Teriak and I'm happy to welcome you to this very special program to kick off the 2021 new year, bringing you the latest and best information possible regarding a global health issue all of us are dealing with every single day, the COVID-19 pandemic. Our guest speaker today is Dr. James T. Noble. Dr. Noble is a graduate of the State University of New York, and he completed his residency at Cornell Cooperating Hospitals. Dr. Noble is board certified in infectious disease and internal medicine, and he completed his fellowship in 1982 at Tufts New England Medical Center. Dr. Noble joined the Concord Hospital medical staff in 2002. His clinical interests include general infectious diseases, HIV and AIDS, the prevention of healthcare-associated infections, and travel and tropical medicine. In addition to his inpatient and clinic responsibilities, Dr. Noble serves as Concord Hospital's Medical Director of Infection Prevention, and he has the lead role in Concord Hospital's COVID-19 response. Please join me in welcoming Dr. Noble.
Thank you, Tia. I'm going to spend the next 45 to 50 minutes going over the past, the present, and the future, what I think is the future of the COVID-19 pandemic. Hopefully it'll be time at the end for questions. I know there are lots of questions that I get every day from all over the place. It is a subject that is both fascinating and to some extent still a bit confusing. So with that, by way of introduction, let's get started. So this is the bad guy here. This is the virus that causes this disease. Its official name is SARS-CoV-2. We'll talk about that in a minute. Why is it a coronavirus? It's because an electron microscopic view of these viruses, they're surrounded by these protein spikes, which to the people who named the virus a long time ago look a little bit like a crown. Corona is Latin for crown, and that's why they're like this. Sometimes poor translations from Mandarin Chinese refer to this as the crown virus, and that's why. We have a fairly long experience with coronaviruses in human biology. There are several different types, which these names are not important: alpha coronaviruses, beta coronaviruses. But what is important is that most of these viruses are relatively harmless. They cause upper respiratory tract infections, colds. Now, it's true that these so-called benign coronaviruses can, on uncommon occasions, cause severe disease. Lower respiratory tract disease, tracheitis, laryngitis, whenever anybody gets intubated because they have laryngeal swelling from a viral infection, there's at least a 50% chance that it's a coronavirus. But most of the time, these pass through our system harmlessly. However, excuse me, we have some experience with severe coronavirus outbreaks, at least since the year 2000. A disease which appeared to arise in China called the Severe Acute Respiratory Syndrome, or SARS, was existing from 2002 to 2003. It skipped from mainland China to Taiwan and then to Canada, where there was a very large outbreak in Toronto. There were some cases that occurred in the United States as a result of that, but for reasons that are not completely clear, after the world distribution of this virus reached 12 to 15,000 cases, the virus disappeared. This outbreak of SARS had a very significant mortality impact. Between 20 and 30% of people who contracted SARS died, and there was a little bit of a lag in getting spun up to implement proper respiratory protection, which is really what was responsible for the large outbreak in Toronto. In 2012, there was a second highly pathogenic human coronavirus called Middle East Respiratory Syndrome. It was originally recognized in Saudi Arabia, where it still is endemic. That is to say, there still are occasionally cases from time to time. It doesn't appear that Middle East respiratory syndrome has very significant human-to-human transmission potential, however. The host animal for MERS are camels. And so there are cases that appear in London from time to time because there's quite a bit of traffic between the Middle East and London, but basically this is an endemic disease in the rural Middle East. Again, very significant mortality potential, but fortunately not very much pandemic or epidemic potential. So that brings me to COVID. COVID stands for, as you see on the top, Coronavirus Disease 2019, COVID-19. It's caused by a newly recognized coronavirus, which was named after a bit of hassling back and forth about what the name should be, SARS-CoV-2. SARS-CoV-2 because the disease that it produces is very similar to SARS-1. The reason to make the distinction is, of course, the enormous epidemic and pandemic potential that this virus has that SARS did not exhibit during its brief sojourn in the human family. This is an EM of SARS-CoV-2, and you see the classic crown appearance of the virus. So, I'm sorry, this is, this really begins, at least to our knowledge in the West, in January of 2020. There was simultaneous publications in the news, in scientific magazines, and on the internet about an outbreak of pneumonia in China. This original link to a seafood market in Wuhan has come under challenge, and I'll explain a little bit about why that's true. The first patient that we saw here in Concord Hospital, we saw on January 17th, and interestingly enough, it was a woman from Wuhan who lives in Concord, who had gone home for a winter holiday and was in Wuhan City on the 25th and 26th of December 2019. I saw her for the first time on the 23rd of January. And her story was that everyone in Wuhan knew, when she was there on the 25th and 26th of December, that there was a huge problem. And I asked her about the seafood market, and she said, oh, no, nobody goes there, that's on the other side of town. We now know, because the virus has been isolated, its RNA has been taken apart, and the sequence has been discovered, and we have sophisticated testing that can be applied looking for it, that the virus was circulating in Italy and France as early as November 2019. There is very, very brisk migration between China, particularly Wuhan, and northern Italy, where Chinese individuals work in factories. And interestingly enough, in order to conform to Italian regulations, a lot of them live on ships that are anchored more than 3 miles off the coast of Italy, and they're boated in every day, so they live in very, very packed conditions. Italy has rules that you can't sell I wouldn't know an Italian branded handbag if it bit me, but you can't sell an Italian branded handbag unless it's actually made in Italy. So these workers come, they live on these ships, they go ashore, they make these handbags, and that is probably the way this got introduced into Europe in the beginning. There are many reports now of cases in late November and early December of what we now recognize as COVID in Western Europe. There was a case now retrospectively identified in New York as early as December 2019. So I think the virus has been around for a little while, but it probably did enter the human population sometime in the late fall of 2019, and that probably happened in China. There was a large event. The military organizations in various countries had a competitive games, playing soccer, football, and Olympic type sports in Wuhan in October that brought tens of thousands of military people from all over the world to Wuhan, who then went home. It's possible that was the source introduction, but by the time this was recognized, it was way too late to do anything about this in terms of global spread. This is a plot that shows current case notifications represented by circles of varying diameters. And what you can see is this virus is everywhere. This virus is spread to South Africa. There's a case, I don't know if you know Tierra del Fuego, the southern tip of Chile and Argentina. There are cases there. There's one case that's been reported from have imposed measures that have constrained the spread of COVID in those countries very effectively. But the big places in the world are Brazil, the United States, Russia, India, and Western Europe, where, as we'll see in a minute, spread of the virus is still occurring very, very robustly. So I think that there were many attempts made to slow down or limit the spread of this virus, but the fact that the virus had already been inoculated into Western Europe and the United States before the true pandemic potential of this was recognized means that whatever you think should or shouldn't have been done, that by the end of January 2020, this was what we've seen happen was destined to occur. The current global situation is on this map. It's represented by colors. Obviously, the darker the color, the more intense the transmission. What you see is that Western Europe and Russia, Brazil, and the United States are the largest areas of transmission. South Africa and Namibia as well have very significant outbreaks that are ongoing. Viral transmission has decreased in Iran, it has decreased in China, and as I mentioned, Australia and New Zealand. And it's never really taken off in sub-Saharan Africa. At the beginning of the pandemic, there was a lot of very reasonable concern that countries with a low socioeconomic development index, highly concentrated urban populations, and poor sanitation would be the places where this virus would take hold and spread the most rapidly. But at least in the case of sub-Saharan Africa, that's turned out not to be true. Are there cases there that get missed? Yes, I'm sure that that's true. But if you look at places in developed countries, Paris, New York, London, where the virus has been so effective at widespread and impact on the population, it's not possible to miss that if that were occurring in Nairobi or in Kinshasa. That just has not happened. The reason that that's true is a little bit unclear. I want to talk a little bit about Australia and New Zealand. Unfortunately, the way I created these slides, poor New Zealand got cut in half here off the coast of Australia. But in March and April, when the virus was increasing rapidly in North America, it was increasing rapidly in Australia as well. We knew people who were students, exchange students in Australia, taking a semester or a year abroad, who were brought home just before the borders closed with Australia. And the number of cases, or the cases per 100,000 population in Australia and the US were comparable at that time. But following the example of New Zealand, which closed their borders in January of 2020, right after expats and foreigners who were not going to remain in Australia had left, Australia also closed their borders. They closed their interstate borders as well, so that if you lived in New South Wales, you couldn't travel to Victoria, and if you lived in Victoria, you couldn't travel to South Australia without permission of the government. And when I say they closed the borders, we're going to talk a little bit later about lockdowns, so-called lockdowns. When I say they closed the borders in states, I mean they put the army on the borders and you couldn't cross. And they implemented a very effective testing and quarantine strategy. Widespread rapid testing was made available to all the cities in Australia, and if you tested positive, you went into quarantine and they checked. They didn't get a little handout explaining what quarantine was and how it worked. They got a tag and they had to stay home, and people went to check that they were staying home, and people who didn't stay home got arrested and quarantined in quarantine facilities. And the result of that has been that New Zealand eliminated the virus from the islands. There have been 2 subsequent introductions of SARS-CoV-2 into New Zealand, both of which burned out very quickly. And Australia has gotten down to very low levels as well. There was a week in December, I believe, where there were 0 cases that occurred in Australia. And I do still see from time to time cases that are imported. Australia is open to China and Southeast Asia, at least for business purposes. And so there are introductions, but if you go, you have to bring a test with you. You get tested when you get off the plane. If you're arriving from an area of concern, you have to quarantine for 14 days in Australia before they let you out to do your business. And so that's been very effective as well. The situation in Western Europe and the United States is sort of the mirror image of that situation. There is widespread sustained virus transmission. We all know the numbers. We've seen the graphs. Even small amounts of social activities we'll see are capable of causing very large outbreaks of viral infection. And I'm going to talk about that in a little bit. This is an intensity map or a heat map of the United States looking at counties where spread of the virus is very intense. And I will point out, it's interesting that Maine and Vermont, this is Maine, and you can see this is Portland here, down where it touches Portsmouth, and Vermont over here where it touches New York. They have a couple of counties with fairly intense spread, but so far, Maine and Vermont have done a little bit better than New Hampshire in terms of intensity of transmission. But a lot of this New Hampshire intensity, as we'll see, is either with cross-border travel to Massachusetts for work purposes or residents in long-term care facilities. That's a special problem that I'm going to mention in a little while. But even at that, if you look at the whole Northeast, starting with Massachusetts here, these colors are considerably lighter than this very band of intense transmission in the Appalachian Mountains in the Midwest and in the Southwest. And the worst state in the United States right now is California, in terms of cases per 100,000, hospitalizations, deaths, etc. We, all of us, have participated in discussions about which states' policies are the best, what policies are the most effective at containing SARS-CoV-2 infections within the context of living in the United States or living anywhere where people vote and can say what's going to be done. And it's very difficult, to my way of thinking, to make, you can use almost any example to prove almost any point that you want to prove. Right now, things in Florida were quite bad in the summer. Beginning in the end of June and going through July and August, Florida had an enormous surge that was shared in part with Alabama, Louisiana, and East Texas. And those were frequently put forward as examples of see what happens if you don't tightly restrict people's social activities. But California, where you get arrested if you go to the beach, has one of the most extreme social distancing and regulation policies imaginable. And if you looked at California in September and October, you see, aha, see, if you do that, you see what happens. You have very low numbers. But right now, California is surging, and their restrictive policies have been intensified, and yet they have this problem. And so in individual cases of households or businesses or hospitals where spread is documented, you can make a dent in that by implementing protective measures, which we're going to talk about in a little while. But on a continental scale, over 3,000 miles of populated territory, I think it's really hard to make the case that we know exactly what's going to work and what's not going to work. And that's obviously important in terms of the future. These are cases, confirmed COVID cases in the US and the European Union, going all the way back to January of last year. And this line is the United States, this line is the European Union. And so in April, May, and June, the EU adopted extremely restrictive policies. In France, which I'm particularly familiar with, you couldn't leave home, you couldn't leave your house, your dwelling place, without a pass from the police, even if you were going to go buy groceries. And you had to call and register and get your pass, and if you didn't do that, you could get arrested and you could be relocated to a quarantine center. And that does, as I mentioned in the case of Australia, that does work. They reduced their new cases down to a very low level, while the United States never really decreased from the so-called surge in March and April very much. And then in Florida, Alabama, Texas, Arizona, we had this so-called second spike in June and July, while the European Union was quite low. But this type of restrictive social policy was found by people living in France, businesses operating in France, etc., to be intolerable. They did it for 9 or 10 weeks, and then they began to loosen, and they went back to what we do. The European Union countries in France, Germany, Italy, Spain. It is often said, when you look at this curve of Europe, that they eliminated their restrictions. That's not correct. What they did is they went to, you're allowed out of your house, universal public masking, no public gatherings greater than N individuals, no indoor events, no opera, no ballet, no movies, no theater, social distancing in restaurants, outdoor dining when possible, etc. So when they converted to a US approach, I guess is what I would call it, they had explosive spread up to the end of September, beginning of October, when they began again to make steps in the direction of doing what they did here. And what they found, I don't know if you read the European papers, Ireland and the UK are going through this right now of trying to impose more and more and more stricter, severe restrictions. And what they're finding is that it's very difficult to do. It's difficult to do because there is a balancing act between other things that are very important priorities. Education of children, for example. People being able to get together at the holidays, for example. And there still is a furious ongoing argument about this, but it does look like their case rates are beginning to decline. So they surpassed the United States in the end of August, beginning of September, were way above us for a while, and now it looks like they're on the way back down, while the US is continuing to have these surges. Let's take a look at what that's like. However, although if you go back and remember that slide, the cases went way up. The deaths per million people of the European Union and the United States have stuck pretty close together in terms of curves. So these numbers are very small numbers, obviously, compared to the large numbers of new cases. But again, there is a lag or discrepancy, I guess I would say, between deaths per million people and whatever social events or activities are taking place. When you look at the question of social activity or mobility over time, excuse me just a second, what you see is that in the US, this is the US only, in the US in the beginning, in March and April, this went way down almost to nothing. Everybody remembers when there were 50 cases per 100,000 in New Hampshire, we shut everything down, we sent everybody home. People tried for a little while to stay indoors. These are parks and outdoor spaces. And then by the end of April or May, people were sick of it, went back up. Then when we started to see increasing numbers of cases at the end of the summer, social activity went back down again in the US. If you look at grocery and pharmacy, which are considered to be generally more essential than participating in outdoor recreational activities, we had the same phenomenon where people went way down in March and then went back up again and stayed fairly constant. Now these two things here are Thanksgiving and Christmas, I think, and this is what everybody has talked about in terms of events that trigger surges, and I'm going to talk about that in a little bit, but remember this slide when we go forward. This is Thanksgiving, this is Christmas, and this is an increase in people's mobility outside of their homes, as you would expect to take place. What we know about transmission. Transmission of this virus is mainly through exposure to respiratory droplets, when close, defined as less than or equal to 6 feet to an infected person. Now, I've participated in innumerable conversations about is 5 feet 11 inches not okay and is 6 feet 1 inch okay. That's not what it is. This number comes from studies of tuberculosis that are almost 100 years old, because tuberculosis is also transmitted by respiratory droplets. And what a respiratory droplet is a germ, an organism that's contained within a small glob of mucus, respiratory secretion, saliva, etc. And when these things are propagated into the air, gravity takes effect. Obviously, the bigger they are, the harder they fall. So that most droplets are on the ground within 6 feet. And this has been studied extensively for TB and for other diseases. So it is a reliable number as a guideline. But of course, there are droplets that are out of the air well before 6 feet. And there are forms of propagation of the virus that can transmit it efficiently beyond 6 feet. But this is a general guideline. It says here, drop particles can remain in the air over time in various distances beyond 6 feet, and that's true. How important these aerosols are in the transmission of SARS-CoV-2 remains intensely controversial. There are examples that have been put forward where that is clearly the case. But what is this epidemiologically important? In other words, should 6 feet be changed to 20 feet? I don't think there's a lot of evidence that that would be a substantial decrement in the epidemic. Less commonly through contact with contaminated surfaces. I would say that if you had contaminated surfaces stock in August, it was a good time to sell it. Because the evidence that all this, somebody in the school had COVID, and so we closed the school for a week because it takes that long to decontaminate. I think that's not as important as preventing this type of contact, which we know in the case of a pandemic, SARS-CoV-2, is very, very important. Virus is found in stool, blood, semen, ocular secretions. The role of this in transmission is completely unknown. There's a very interesting paper that was just published about residents in high-rise buildings. And without being too graphic about it, if you live on the 80th floor of an apartment building, when you flush the toilet, the contents of the toilet has a long way to travel. And as it travels, it goes through various traps. And they have found SARS-CoV-2 in the air, remote from dwelling places of people who are excreting SARS-CoV-2 in their stool. And the hypothesis is that these systems for removing wastewater that are vertical have failure points, so that aerosols can actually be generated while the water's on the way outside the building. And the place that's actually done the most research on this is Hong Kong. And I think that it's a pretty good story. Whether this has any practical importance in terms of what people should do now today in New Hampshire about this, I think is somewhat obscure, but it is an interesting additional potential means of transmission. We've adopted a structured approach to prevention here in the hospital. The fundamentals are universal masks, physical distancing, avoiding crowding together in congregate settings. This is actually surprisingly difficult to accomplish on an 8 or 12-hour workday schedule, 365 days a year. People need to take breaks. People need to eat food. People need to drink fluids while they're working. And obviously you can't eat and drink while you're wearing a mask. And people also need human contact, other than work-related human contact in the course of a day or a week or a month or a year. But any outbreaks that have occurred in healthcare settings in New Hampshire, in acute healthcare settings in New Hampshire, have not been related to contact with patients while wearing PPE, but rather have been related to congregating together when finally you can put your burden down, you can take your mask off, you can do other things that you need to do. And this remains, in the context of pandemic coronavirus, a dangerous thing. Outdoors is better than indoors for sure, and frequent washing of hands is important for two reasons. Number one, it prevents the virus that's on your hands from getting elsewhere on your body, and number two, it functions as a reminder for all your other stuff that you need to be doing in terms of protecting yourself. This is the disease, COVID. Fever, cough are the sentinel manifestations of the disease. This was taken from China, but this has been true all over the world. Fatigue, shortness of breath, loss of appetite. Very interesting is loss of smell and taste preceding the onset of these symptoms. We see this a lot. In fact, I think now, I think it's safe to say now that someone who comes in because they're ill, they're running a low-grade temperature, they've started to feel a little bit breathless or coughing, and they tell you that 2 or 3 days ago, they lost the sense of taste or smell. This is COVID 99.9% of the time. We've never seen this as a symptom, certainly not of a highly transmissible respiratory virus. And it probably has to do with the way the virus gets into the system once it's in the nose. It is isolatable from what's called the cribriform plate, where the nerves that let you smell enter into the nasopharynx. And when there's a lot of virus there, it can make this go away. This usually comes back, by the way. Not always, but almost all recovered patients who have lost their taste and smell will have this come back. Interestingly, there's a case report of 4 or 5 people whose taste and smell senses came back, but they were different. So when they smell something that smelled one way, now it smells a different way. Sometimes it smells better, sometimes it smells worse. That has not been a common thing, but it's another sort of interesting aspect of this symptom. Among people in Wuhan, 44,000 people were studied. 81% of them had mild to moderate disease, 14% had severe disease, and 5% had critical illness. And this is held up pretty well also in the US context. Maybe severe and critical are a little bit less common. Case fatality rate, I'm sure you've all seen on the internet, there are people who insist that the mortality rate of this disease is 0.0001%. That's not true. I don't know if it's as high as 2.3%. I think the consensus number that people are working with now is around 1 to 1.5%. With 300 million people in the United States, 1% is 3 million people. So that's a big number. We're not used to dealing with commonly transmissible respiratory infections with mortality that's anything like this. I've practiced infectious diseases through 41 influenza seasons, and I've never seen anything remotely resembling this in terms of hospitalization, impact on well-being. And so you could say, yeah, well, gee, it's only 1%, and it's only fat people, or it's only old people, or whatever. It's a big deal. Look at SARS, for example. If the mortality of SARS-1 were 1% and it affected only 12,000 people, well, yeah, that's sad, but that's not that big of a deal. If you have a virus that can infect every human being on Earth that has a 1% mortality, that's a very huge deal. And so that I think is the reason for the intensive activity around prevention and, as we'll see, how to aggressively combat the disease. Risk factors for severe disease are age and underlying medical conditions. The big ones are obesity, diabetes, and hypertension. Why hypertension is unclear. One of the things the virus does is it attaches to a receptor in the lung, the blockage of which is the pathway for one of the most commonly used antihypertensive drugs. It doesn't seem to be the case that taking losartan, which is the drug, increases your risk of COVID. So that's not the answer, but there's something about people who are hypertensive. Maybe it has to do with their microcirculation in the lungs. I don't know, but that is clearly a risk factor. But we're going to circle back to this when we talk about treatments, because it's important to be able to assess risk. Now, older adults, this is a very common misunderstanding. The breakdown of population data about COVID usually stops at 60 to 69 and greater than 70. And there's a big jump between 60 to 60. There's a big jump between 50 to 59. There's another big jump from 60 to 69. And then there's a very, very big jump from in the greater than 70 group. But if you break the greater than 70 group down into 70 to 75, 76 to 80, 80 to 85, 86 to 90, 90 to 95 and plus, you see the same phenomenon. The curve continues to rise. And so it's not true that the mortality, most of the mortality and severe disease that occurs in people who are over 70 occurs in people who are over 80 and over 90. So the risk that's associated with advanced age persists no matter how you break down the demographics. Long-term effects, this is another very important issue. People can recover from COVID, young people especially recover without any residual injury, but there are people, what are now called long haulers, who seem to have smoldering disease, who have lingering problems that can cause brain injury, cardiac injury, especially lung injury. This is one of the big issues about sports, about athletics and young people. Young athletes are the people who are the quickest to recover from COVID, but they're also the people who are at greatest risk of short-term harm from lung injury or cardiac injury. And we're really just beginning to come to terms with this, because people who have 2 days of aches and pains and a day of sniffles are not people who experimental therapy is going to be targeted at right away. But we just don't know what the size and shape of this issue is, which, as I'm going to get to, was why we need to do vaccination and why we need to get rid of the stupid virus to begin with, so we don't have to figure this out. So that's sort of the past, a little bit of the present. We're going to talk about the present now for a while, and then hopefully the future. These are new cases in New Hampshire through yesterday. And what you see here is, this was the crisis when all the hospitals were shut down and we were building temporary hospitals with hundreds of beds, and people were not able to go to work and people were not able to go to their house. I actually have a family member who left their house for the first time 2 days ago, since March. So this event here was, at the time, perceived as a civilization-altering crisis. If you remember, if you go to receive healthcare services here, people were doing telemedicine, people were not going to the office, etc. So this was this, and by the summer, this really cooled off quite a bit, to the point that people were more relaxed about social activities. And then beginning, I guess, end of September, to be fair, but the New Hampshire, this is what would be called a surge in anybody's lexicon. And the New Hampshire surge really begins just after Halloween, 3rd or 4th of November, and peaks and starts to decline around December 8th. So we had a 5-week-long surge, which was very intense, very challenging. Unlike the spring, we shut down healthcare in the state. I don't mean we, by we, I don't mean Concord. We shut down healthcare in the state when we peaked at 56 cases per 100,000. And we got up to nearly 1,000 cases per 100,000 here. Certainly we were in the 900s for a number of days. The thing about this curve that I want to draw your attention to is that there have been surges elsewhere, all over the world, in New York City, Padua, Italy. There are surges in the UK and Ireland. They all have a similar shape, which is that this part of the surge, this is living in crazy town if you do healthcare. When this is going on, every day is worse than the day before, and sometimes a lot worse than the day before. And it feels like this is never going to end, this is never going to stop. There's always a peak, and then it starts to go down. And the decline is usually what I have referred to as a sawtooth decline. That is, it's not true that every day is better than the day before. There are days, as we're going to see in a minute, that are worse than the day before. But the pattern, once the pattern begins, there's something about the virus and the way it interacts with the population that, there's a saying, trees don't grow to the sky. We don't know where this is going to go, but we know it's not going to go here, right? Not this time. It's going to decline, and it's going to continue to decline. And we've experienced this in the building as well. Now, remember, after you test positive for COVID, if you're going to be sick enough to be hospitalized, it takes between 10 and 14 days for that to happen. So if you follow hospital admissions, they went up a lot during this time. Obviously, there was a near crisis over availability of hospital resources, but part of that was because normal hospital activity was continuing during this time, as opposed to April, late March and April, but also because there's an offset. So the rising curve of hospital admissions is not going to be the same time, but will be delayed after the increase in cases. So this is a graph of hospitalizations in New Hampshire, and you see that they're still, as of a couple days ago, they were still going up. But again, this was offset from the decline in the new case thing, and I think we will continue to see, as we are seeing here, a decline in new hospitalizations. Deaths, again, spiked and have declined, although we did have a very bad day, I think, yesterday. One of the things about deaths, I guess it makes sense if you think about it for a minute, is that most of these deaths are occurring in very elderly people, or people who are compromised in other ways. Not all. The youngest person to die in our area that I'm familiar with was 29 years old, so that can happen. But the vast number of these deaths are occurring in very elderly people, many of whom exist still in congregate living situations. And so this curve is not going to trend the same as the population curve, because there will be areas of intense or focal activity. But we did peak and begin to decline by the first of the year in general. This slide is only current through the 3rd, and there has, as I mentioned, been another uptick in deaths, although not in hospitalizations for COVID. This is statewide testing, looking at the percentage of people who are positive for COVID by either antigen testing or PCR testing. Gets smoothed out into a 7-day average, so it's not spiking all over the case. And we saw the same thing, which is this went way up, it plateaued, and now is declining. If you look at our testing, this is the last 10 days of testing in the hospital. Last week of December, first week of January, we had a 10.2% positive test rate. This dropped down to 8% now. And the positivity rate in the state, I think, has declined to 7.5% or something like that after peaking in the teens. So all these trends are positive trends, but consistent with what I showed you already, which is that these things do rise and fall. This is the midnight COVID census in the hospital. I didn't have time to put today's slide in, but we see the same, what I referred to as this all went up, and then this is what I call the sawtooth decline. There are days that are worse, but the trend, the slope is still a negative slope, and indeed today's numbers are down around here somewhere. So our peak midnight COVID census in the middle of December was 52 patients, and last night we were 17. So we've seen substantial improvements along those lines as well. Talking a little bit about prevention, both in facilities and elsewhere, we use a multi-step approach. One is elimination of opportunities to transmit, 2, substitution of methods and practices, 3, engineering controls to deal with the environment, 4 is administrative controls to deal with how we work, and last, but very important, personal protective equipment, which everybody's heard a lot about. Elimination means removing potential reservoirs of infection using telehealth, restricting visitors, allowing people to work remotely. These all decrease the density of patients, visitors, and people on site and eliminate risk of transmission from those groups. But there's care that this is not feasible. One of the things that we learned in the spring was that there were cases of SARS-CoV-2 that were prevented by eliminating routine medical care, but there were people who didn't have cancer surgery that they needed, there were people who didn't have heart testing that they needed, and there is not only morbidity but mortality associated with this type of restriction, which is why hospitals in November, December, and beginning of January have tried so hard to keep normal workflow up while caring for the large number of COVID patients. It's because it's not really an either-or situation, it's a both-and situation. Substitution, we use a lot of disposable equipment now. We use surfaces that are easier to clean. We've made alternative arrangements for registration and patient waiting, and we've adopted a number of new cleaning materials to better decontaminate the environment. Engineering controls, physical barriers, you've all seen these in the cafeteria, in triage and registration to keep people apart. People can register remotely. We separate evaluation locations for COVID. We have a clinic, as you know, in the Memorial Building where we assess people with symptoms, get tested for COVID, and soon we'll be treating them from there as well. We use, let me go back. We use private rooms for people with suspected COVID, use of airborne isolation when they have it, and make sure that our air handling systems are up to grade. We built, I think, somewhere in the neighborhood of 60 COVID beds in the spring, and we've kept them online until very recently, just to have them available in the event of need. Administrative controls, you all know when you come to work here, you have to sign on every morning on a mobile device or when you arrive at work, and attest that you don't have fever, that you don't have other symptoms that are consistent with COVID. We screen patients and visitors the same way. We do pre-visit paperwork and a lot of practices remotely, promote physical distancing. We've talked about a lot of these other things, limiting people going to hospitals in outpatient settings by telephone and telemedicine, and limitation of visitors. Personal protection, of course, universal source control, eye protection, which is mandatory if you're doing patient care in the hospital now. Additional PPE based on standard and transmission-based precautions. People are using face shields now commonly for patient care, if not goggles that protect their eyes. Use of surgical or procedure masks, except in people who have aerosolizing procedures or symptoms and positive COVID tests. And we've had to implement extended use and reuse because still, unbelievably, after 10 months, these things are still difficult to acquire. Prior to the big surge in December, we built up a 6-month supply of this stuff. We opened up that supply on, I believe it was December 7th or 8th, and obviously we're consuming it rapidly. Fortunately, our need for it has decreased as well. Okay, I want to talk about the future a little bit and then see if there's any questions. This is a schematic about the disease. We've learned a lot about the disease since the spring. And the key concepts are that there's a period after you acquire the virus and before you develop symptoms when the virus is reproducing itself very rapidly in the upper respiratory tract. If we could know when this is when we would want to treat people with effective therapy, but we can't know when this is. When symptoms begin, the symptoms are caused by the immune system's attack on the virus. And because the virus is new, well, I shouldn't say that. It is a fact that the virus is new, and it is a fact that the immune system on this virus also injures parts of the body, or can do so. So that by the time you recognize somebody with COVID that has symptoms, because their immune dysregulation is causing the virus to disappear, the amount of virus in the system begins to decline right away. It's unfortunate that a lot of the studies that have been done about how should we treat COVID with antiviral things, and I'm going to talk about them in a minute, has grouped all these people together as if they had a single disease or phenomenon. It's obvious that an effective antiviral is not going to be effective here because there's no more virus to be effective with. there's antibody. Any virus that's remaining in the body has either been broken up by the body's host defenses, is being trapped in antigen-antibody complexes, and not able to be transmitted, but this harm goes on. And so there's really, because it's a biphasic disease, a viral replication and then immune injury, there's a rationale for antiviral treatment in the beginning, and then there's a rationale for anti-inflammatory treatment. Now, this slide makes this look like you could say, okay, here's a patient who's had symptoms for 4 days, they got tested 2 days ago, so that's 6, and here's 5, and here's 11, so they're here, so we're going to do that. Unfortunately, that's not the case. It's probably true that everybody's COVID map looks different. And it's probably also true that not everybody with COVID goes through every single one of these phases. So we are sort of still fumbling to try to identify in each individual patient where they're at with this and what's going to be of benefit to them. One of the biggest breakthroughs, and the reason that the deaths are down so much in the United States, is the recognition that early use of anti-inflammatory treatment in patients who have good evidence of cellular injury from their T cells and antibodies is life-saving. And most of the studies that prove this were done with a steroid called dexamethasone or Decadron, and that's why Decadron is in most treatment schemes. There's no reason to believe that Decadron is more effective than methylprednisolone, for example. It's just that that's the drug that's been the best studied, and that's the one that's the most widely used. So if you get admitted here now with a positive COVID test and hypoxemia, abnormal oxygen function, an abnormal x-ray or evidence of lung injury, you're probably going to get Decadron, and that's the reason why. Antivirals, as I mentioned, are much more difficult to study because they're going to be most effective in this part of the disease. And finding somebody who's right here without a scheme to test everybody every day, and there are people who have proposed such a scheme. Michael Mina at Harvard is one of the most prominent advocates for doing this, doing exactly this. We're not at a place where we could reasonably do that. And so the usual way we find somebody like this is somebody who has developed a lot of symptoms: fever, malaise, cough, headache, maybe diarrhea, maybe muscle aches. And they are either aware of a COVID exposure or they're more concerned than the average bear about COVID exposure, and they go get tested. And then they call and they say, I have these symptoms, I got tested, I'm positive, and we come in and they're not hypoxic, they look like they're going to do okay. Standard approach to those people, which is unfortunately still the standard approach today, is to say, go home, monitor yourself. If you feel like you're getting worse, you can't breathe, blah, 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 come in. So people are coming in now 8 days, 9 days, 10 days, 14 days after they're diagnosed when they're in a lot of trouble. If that's their destiny, if this part of the disease takes hold, we're starting to try to treat people here instead of treating people here. Now, one of the reasons that we have failed at treating people here is we don't have very good effective antivirals. There's a drug called remdesivir, which was approved for emergency use in May and approved for widespread use in September. That is an antiviral. It does inhibit SARS-CoV-2. But a lot of people for whom remdesivir is approved are people who are in this phase of the disease. And so you'll see papers that say remdesivir works. You'll see papers that say remdesivir doesn't work. And really, that's just based on what group of patients were studied in that particular study. If you get admitted to this hospital, oh, by the way, excuse me, remdesivir is approved only for inpatient use. So if you get admitted to this hospital and you're hypoxic and you're symptomatic, it's highly likely that you'll get both remdesivir and dexamethasone, and that is life-saving for a lot of people. But really, I think where the future is taking us is back to this part of the disease, and I'm going to talk about that hopefully a little bit. It's still true that these are the only two recommended drugs for treating COVID, and I've talked about this. Other investigational antivirals, plasma, monoclonal antibodies, I'm going to spend some time talking about. Immunomodulators that basically turn off or turn down T cell responses, and then anticoagulation. I should have mentioned that. Let me go back to this for a minute. One of the things that happens here, and one of the main reasons people die, is because clots form in the small blood vessels in the lung. Part of what this virus does is trigger this clotting cascade. And we know that if you do this early enough, that you can actually save people's lives by shutting off this process. As with steroid therapy, though, there's a downside. If you really anticoagulate people too much, some people are going to bleed. And some of the people who are going to bleed in their head and they're going to die. So again, it's a very difficult cost-benefit analysis balancing act to decide when you're going to start anticoagulation. So let me just see where we are next. Oh yeah, I want to talk about vaccine and then circle back a little bit to treatment. The government approved in April a very, very gutsy and now I think a successful thing called Operation Warp Speed. And in terms of vaccination, Operation Warp Speed did two things. One is it made everybody who wanted to get approval for and eventually market a SARS-CoV-2 vaccine in the United States to use the same protocols for testing. This is very uncommon. If there's 6 or 7 new oral antifungal medications that are being tested, for example, Pfizer will test it their way, Lilly will test it their way, Upjohn will test it their way, and so when you come to the end and you have to compare, is this one or this one or this one the best one, your source of information is salesmen who are telling you, this, we did this, we did this, we did this, and based on long experience, I can tell you, these trials are usually designed with the end market in mind. If you're studying an antifungal drug and you need to get X number of dollars, you have to make a decision about whether you're going to treat genital candidiasis as your target of your study or whether you're going to treat brain abscesses with a fungus as the target of your study. And so when the study's done and the drug is approved, it's really hard to compare them. But the government made them all do this the same way. And they said, okay, and we're going to promise you two things. We're going to promise you that if you get to the point of approval, we're going to buy this much vaccine from you. In the case of Pfizer vaccine, which is hurting my arm today, the government promised to buy 100 million doses of Pfizer vaccine if Pfizer's vaccine got to approval. In the case of Moderna vaccine, which some of you have already gotten, they promised to buy 200 million doses. So evaluation the same way, steps toward getting approval the same, and a promise to pay for it has produced really an amazingly quick result. There are 2 vaccines that are now available under emergency use authorization, Moderna and Pfizer's vaccine. Their phase 2-3 studies are still ongoing, but they received EUA for them and people are being vaccinated here today. There are other vaccines that are just around the corner. Janssen and Oxford universities, which is also known in the US as AstraZeneca vaccine. This one is very close to approval. The Merck vaccine is going to be approved probably in March. These protein subunit vaccines have not done as well. The Sanofi vaccine, I think, is going to be a failure. The Novavax vaccine, probably not till the beginning of the summer. But bottom line is that the government has recently increased their buy of the Pfizer vaccine to 200 million doses, and Pfizer's promised to provide them. So we're going to have enough vaccine for everybody in the population in very short order. I mean, March, April, I'm talking about. And this is an extraordinary outcome or extraordinary benefit of this Operation Warp Speed. So if anybody ever says, which, is semi-credible, that the government never does anything good to you, you can always point to Operation Warp Speed if you feel like sticking up to them. This is our vaccine record from 2 days ago now. We had given 1,350 doses, of which 1,279 were first doses, and we were starting to give second doses. We've identified 2,496 high-risk healthcare workers and invited them to receive vaccine. About 75% of them now have signed up to be vaccinated, and so this is going forward very rapidly, which we have a very positive feeling about. So I'm going to put up the conclusion slide, but I want to talk a little bit about the monoclonal antibodies. In the spring, there was a lot of talk about the benefits of what was called convalescent plasma. And people, even who recovered from COVID, would call and say, can I donate my plasma to be given to patients? Most of the convalescent plasma trials were done in patients who were what we now know as end-stage disease, in an ICU, on a ventilator, virus all gone, inflammatory manifestations dominant. We didn't know that at the time, of course. And so most clinicians who were involved in convalescent plasma trials would tell you, this isn't any good, this is not going to turn into anything. But the real issue with the convalescent plasma trials is that most of them were done without knowing how much antibody was in the product, because not every patient makes the same amount of antibody. So some people got convalescent plasma with no antibodies in it, some people got convalescent plasma with a lot of antibodies in it, and they got it at a stage of disease where it was unlikely to be helpful. But there were cases, remarkable cases, where people got better when they got it. And so the biotech industry went to do something better, which was to make the antibodies by cloning IgG against a specific target that exists on the virus and nowhere else. And in, I believe it was in September, the first results of clinical trials of the two monoclonal antibodies that exist now, one is called Regeneron, and the other called Bamlanivimab is the name of it. I call it BMAB because I can't say that more than 2 times without it coming out as Ramalama Ding Dong. But basically, they are available for infusion in people who are not hospitalized, who don't have an oxygen need, and who have early diagnosis of COVID. And if you treat somebody like that, who also has a lot of symptoms, headache, pain behind the eyes, muscle aches, sweating, maybe a little bit breathless, maybe a little bit coughing, not a lot of evidence of tissue injury, no evidence of clotting going on, they will call you in 6 hours and say, it's a miracle. What did you do? This is the greatest thing that ever happened to me. And so we started, this drug is available, these two drugs are available through the emergency use authorization process. And we started with 3 doses. They're all allocated centrally, so they come from the federal government to the states, and the states then give them out. We started in early December with an allocation of 3 doses. And so we set up a process where this is done in the emergency room. It didn't seem like an excessive burden to give to the emergency room to do 3 people in a week. Right? You can squeeze that in between heart attacks and broken bones. And so that was done. And what we found, of course, is that the more you give, the more you get. And so lately we've had 20 and 20 plus doses of this product available weekly to give to people who fit this category. And it comes back to what I said earlier. It's really hard to find without a test for how much virus you have, and that's not coming soon if it comes ever. Without having that, it's really hard to find who the right people are to give this to. But we do find them, and we are treating them. And we are developing a process which is not yet live, but which will be live soon, of a central location that's not the emergency room where people can go to get this antibody treatment. And this is going to be connected to our NEC, our evaluation center, so people who test positive and who are seen by a doctor or a nurse practitioner who have symptoms, have early disease, and who don't have lung injury or oxygen need, this is going to be more widely available to them in the near future. So to summarize, things are getting better, especially deaths. It's a true statement that there were more deaths in New Hampshire yesterday than ever before, but it's also true that there have been more cases in New Hampshire yesterday than ever before. The chances of dying from COVID, if you're hospitalized, have gone down and continue to go down. Our understanding of this complex disease is improving, and so is our ability to treat it. Widespread distribution of vaccines is occurring. New cases are much younger and healthier than those in the spring of 2020. That's bad because they have to get it, but it's good because their chances of dying are much less. And we've come through the latest surge in excellent shape. As I mentioned to you earlier in the talk, 2 weeks ago we had a midnight census of 52, and 2 nights ago it was 17. So I think the future is bright. I think the vaccine's going to make a big difference. I think the monoclonal antibodies are already making a difference. And there's lots of work being done on antiviral drugs, about which I didn't have time to speak, but there'll be a lot of stuff in that as well. And so that's it. That's the past, the present, the future. And if people have questions, I'd be happy to take them. Yes?
Dr. Noble, I understand that none of the vaccines right now that are either in production or going to be in production are for under 16 years old. Is there talk of that? Yeah,
I don't. One of the vaccines is approved for down to 16, and one of them is approved for down to 18. And there's a very pointless discussion going on about, you know, can you give the 18 to a 16? Yeah, obviously you can. It's much harder in the United States to study anything in children. That's just how it is. And I'm not a pediatrician, and we have very little contact with a SARS-CoV-2 positive pediatric population. But yes, it's an area of intense interest and research, and you should be hearing more about it soon. Pamela?
Yeah, Dr. Noble, for people who are age
Well, if the asymptomatic positive group was a single thing, I think we could answer the question, but the problem is that, first of all, let's talk about, that's really three questions. So the first question is, what does it mean to be positive? Okay, what it means to be positive is that a technique called gene amplification, or PCR, can find a gene that belongs to this virus that's nothing else in your nose, or rarely in your throat, but basically in your nose. So that's what being positive means. Now, being positive doesn't mean you're going to get sick, and being positive doesn't tell us how long you've been positive. So if you could know that somebody who you see is positive now has a viral load of 10 million, and in 3 days is going to be hypoxic, yes, of course, we would treat all those people with monoclonal antibodies or antivirals or both, but we can't find them. So the advice to an asymptomatically positive person remains to just keep an eye on things, because many of those people never develop any symptoms. And they either are recovered by the time you see them or recover shortly thereafter. I'm not very optimistic that we're going to have a viral load measurement that's clinically relevant. We use viral load measurements in every HIV positive patient every 3 months, and it still takes 2 weeks for the result to come back. Now, that's not operationally a problem in treating HIV patients, but it will be useless in treating this disease. So I'm afraid that's not a good answer to your question, but it's not a homogeneous group about which you can make a decision about what should be done.
Question.
Yeah.
We have a question online.
Sure.
Do we know?
Before we do questions, I have to leave at 1:15.
Okay.
Go ahead.
Do we know if earlier treatment prevents more of the long-term effects?
We don't know that. It's logical to believe that would be true, but we don't know. Yes, Pamela?
Do we know whether there are any natural immunities to this disease? Meaning
Super, yes,
like
yes.
a low positive blood type or something?
No, well, yeah, yes, there's a number of risk factors that are demographic in nature for bad outcomes of COVID. And the United States is probably the least likely place on earth to study those in a rigorous way about the impacts of demographics on disease outcomes. There is natural immunity let me just, bear with me for a second. I want to go back, because it'll make sense with the slide up here. So, some of this that you see, this is April, some of this is natural immunity. Some of this, the virus has infected all the people it can infect, and there's other people it can't infect. And it's been shown over and over again that there are some people that have T-cell immunity to coronaviruses that cause colds that are able to resist infection with SARS-CoV-2. Now, it's not that simple, because everybody has some immunity. Everybody's had a cold. Everybody has some immunity to some coronaviruses. There's only 6, I think, human types that cause respiratory infections other than, the bad ones we've talked about. So yes, there are individuals, they tend to be younger, who have cellular immunity that, even though they've never seen SARS-CoV-2 and they don't have antibodies, when you mix their T lymphocytes with SARS-CoV-2, the T lymphocytes get all excited. So that does exist. In a different life, I did actually measure in a test tube the activation of lymphocytes in human infections. This is not a practical thing to do. It takes weeks to get a result, and you can do one person at a time. So it's not a screening test that we're going to develop. But in the sense behind your question is a true thing, that there are people in the population, we don't know how many, who were able naturally to resist infection with COVID. And if we knew how many, if we knew that was 80% or 5%, that would be a very useful thing to know, but we don't know. It certainly appears that it's easy for a lot of people to get infected in a hurry. That's also true. Yeah.
I guess maybe would explain some of the families who have had a positive patient in the household and then the others did not.
You would imagine that it would be 100%, and it's not 100%, and it's not close. And if you look at the shifts, there were 2 outbreaks on ships, one on a cruise ship called the Diamond Princess and one on an American aircraft carrier called the Theodore Roosevelt, that occurred at about the same time under very different circumstances. The Diamond Princess infection rate, I think, got up to 70%, but it wasn't 100. And when they went on the ship, yeah, there was virus in the air, there was virus on the walls, there was virus in the buffet, but not everybody got infected. On the Theodore Roosevelt, it was very interesting because the Navy already had anti-COVID measures in place. They had a port call in Vietnam, of all places. I'm of an age when that seems like it's unimaginable, but I know what happened. So they had a port call in Vietnam, and they screened everybody when they got off the ship, and they screened everybody when they got back on the ship. And the first illness was 3 or 4 days after they left Da Nang, and the susceptibles got infected in 4 days or something like that. And there were many people who didn't get infected. So it's the same. Yeah, it's true, but it's hard to work it into a scheme for either public health or patient care. We will hopefully, just one last thing, we will hopefully learn soon that vaccination prevents ongoing transmission. And that's, in case that's questions in the queue, that's an important question that I didn't get to. The statement has been repeated that the vaccination does not keep you from getting infected and it doesn't keep you from transmitting the virus to other people. It just keeps you from getting very sick. That's not true. It's not false, but it's not true. The reason that's so is that what Operation Warp Speed said, we want you to study whether this prevents you from getting very sick or dying. And as soon as you know the answer, we want to vaccinate everybody. So a study to show that you can't contract the virus at all or that you can't transmit it would be going on until 2023. And we don't have until 2023 to do these vaccines. So that's where that's at. It's a different question. It's a bigger study. It's a longer study. It's a different kind of thing. Yeah, sorry.
Are you seeing people getting the virus again after already having it?
It's a two-part question. So in epidemiology, there's a thing called a surveillance definition. That is to say, so if you were studying Legionnaire's disease, for example, in Philadelphia before you've isolated the germ, you have to have a case definition of who has it. So if you belong to the American Legion, if you stayed at the Bellevue Stratford Hotel between this day and that day, and you were hospitalized back home in Ohio with pneumonia, and you didn't grow any normal pneumonia germs out of your lung, you're assigned a diagnosis of what was then called Legionnaires' syndrome. Okay? Not all those people have it, but they meet a surveillance definition that lets you begin to measure the size and shape of the problem. So there's a surveillance definition for reinfection with COVID, and the surveillance definition is being positive 90 days after you were positive for the first time. Okay? Not all those people are reinfected. A lot of those people are continuing to degrade the virus in their nasopharynx and continuing to have a positive PCR. It looks as if you can get reinfected, but that it's rare. And it's not believed to be epidemiologically important in terms of sustaining the epidemic or the pandemic.
I have someone who is
Just keep
asking.
talking.
I'm allergic to the flu shot. Should I be concerned with getting the vaccine?
Yes, there's a screening process for allergy, and being allergic to any vaccine is a contraindication to this vaccine. Yes?
How concerned are you with the new virulent, the new strain?
Well, again, like I've often said, that a week in COVID time is like a year in real time. We've known that the virus is mutating continuously, and we've known that for months. So there's strains and there's strains. I've read a paper that has not been. One of the things that happened very early in the course of the pandemic was a website was set up where if you wrote a COVID paper that you submitted to a journal to be published, which usually takes between 8 and 15 months between the time you're done typing and the time it's in print. Okay, there's a website where you can put this, you submit this paper to the New England Journal of Medicine or to Lancet or whatever, and you also put it on this website. So we've gotten into the very bad habit of referring to these online posts as publications, which they're not. They're just somebody's work, and it has not yet been subjected to criticism. A lot of papers that get submitted don't get published because the reviewers realize that they're not valuable. So I've read the UK publication several times, and I still must say I don't quite understand what it means. The UK variant, the so-called UK variant, can apparently infect more people faster than the previous variant that was in the UK, but does not cause more severe disease. And it is said that both the monoclonal antibodies and the vaccine are not defeated by this strain. That being true, I'm not even sure how you would, you know, I'm not a reviewer on that paper, so I can't say like what constitutes 60% more infectious, but it seems kind of vague. The South African variant, which is already present in the southern United States, is a more elaborately changed virus. But again, the target for the monoclonal antibodies and for the vaccine is the so-called spike, the part of the virus that attaches to human cells and lets it infect them. And you saw the little crown, right, the spikes. So all viruses that have that have a region that's constantly changing and a region that doesn't change. So whether that's true of this virus, we don't know, but that's typical of viral attachment spikes. And the people who make the monoclonal antibodies and who make the vaccines are quite confident that their target is non-varying regions of that spike. So I'm interested in it, but I haven't had time to be concerned about it yet. I'm not sure being concerned about it is reasonable at this point.
Thank you.
Okay.
That's it?
Yes.
Thank you all.
Thank you so much, Dr. Noble, for, it's been a privilege to have you today as our What's Up Doc speaker. Thank you for sharing your knowledge, your expertise, and giving us the facts.
Thank you.
Thank you, everyone, for joining us live stream. We look forward to bringing you What's Up Doc next month on February 12th. And we look forward to having Dr. Matthew Gibb, our Chief Clinical Officer, talk about our Cardiovascular Institute. Have a great day. Happy New Year from the entire staff of the Concord Hospital Trust.